Hi, everyone. You are listening to Beyond, and I'm your host, Dr. Flora. Listen, life is hard. You don't have to do it alone. As a mindset coach, physician, mom, and an infertility warrior, I have mastered techniques to help move you towards contentment and growth. I can't wait to go along with this crazy ass life journey with you while making sure you feel like your best self. This podcast is meant to have you feel unstuck from your rut and less alone. Let's do this. Hi, Beyond listeners. It's your host, Dr. Flora. I am so excited for my guest today because everyone is talking about the hottest topic here on Instagram, in doctors' offices, how to lose weight and Ozempic and all the other medications that you've heard about. I have a specialist here today to break all of this down for you so you can understand what steps you can take towards bettering your health. Dr. Arti Thangudu is a distinguished triple board certified physician specializing in endocrinology and lifestyle medicine. So yes, she is a specialist in the field of optimizing your health through nutrition, through exercise, stress management, sleep hygiene, and eliminating unhealthy habits. As a passionate advocate for patient-centered care, she emphasizes building strong doctor-patient relationships within her practice, focusing on very common conditions that I know you've heard of, like obesity, diabetes, high blood pressure, thyroid disorders, high cholesterol, and other hormonal conditions. She has established 2 healthcare companies. Her first venture, Complete Medicine, is a direct specialty care clinic in endocrinology and then she later founded Hey Healthy, which helps businesses improve employee health by providing accessible and supportive diabetes and hormonal care. Dr. Arti is married to medicine, just like I am. She's married to an ICU physician, and she is a proud mama of 2 littles. Arti, welcome to the Beyond podcast. I am so excited to have you here.
Well, thank you for that beautiful intro, and I am so excited to chat with you today. Thank you for having me.
Of course. So let's just jump right in. First and foremost, what is an endocrinologist? Let's break that down.
I know endocrinology is like this long, funny word that makes no sense to a lot of people. I feel like with other specialties, it's localized to the part of the body that it's talking about or that it covers, and endocrinology doesn't have a localized spot. So as endocrinologists, we take care of hormonal conditions. So hormonal and metabolic conditions. So anything that has to do with the hormone, we're your specialty. Diabetes is the disease that we take care of most commonly. And for those of you like, well, that's not a hormonal disease. Well, it is. Insulin's a hormone. So diabetes is probably 80% of our practice because that is just the most prevalent disease that we take care of. Next would be thyroid disease. We take care of metabolic thyroid disease, which is hyper and hypothyroidism, structural thyroid disease, which would be like thyroid nodules, thyroid cancer, things like that. And adrenal diseases that can be like Cushing's, high cortisol, low cortisol, or Addison's disease. We take care of adrenal tumors. We take care of female and male hormone disorders, low testosterone, menopause, perimenopause, PCOS, those types of things. And we also take care of pituitary disorders, which is the kind of boss gland of the rest of the body. It tells the other glands what to do. So we have a whole body specialty. That's why we don't have a particular part that is pointed out in our name. But we do a lot of things that people may not know about. So I think that's a great place to start.
Yeah, a hormone doctor is kind of how I describe it to my own patients who aren't sure why I'm sending them to an endocrinologist. As a primary care physician, we can only go so far with, we obviously also manage thyroid disorders and diabetes and other very common metabolic conditions. But again, when we need you guys, it's really important for patients to understand why we're sending them to a specialist in endocrinology. Hormones affect everything. And that's why I think, to kind of prove your point, where I can't say, okay, well, Dr. Arti is going to be taking care of this specific part on your body and show it to them on, on the screen, because hormones can affect everything and anything. So I know, as of, I maybe like in the last 10 years, I feel like hormones have been such a hot topic. What are your thoughts on a lot of these trendy phrases that have come up? For example, I see patients almost weekly, if not daily, who ask me to test them for something like uh, uh, adrenal fatigue, or high cortisol level because they're feeling anxious, or they can't lose weight. What are your thoughts on all of that from a traditionally trained Western medicine standpoint?
Yeah, I think hormones play a role in a lot of the way we feel. And so I think it's appropriate for patients to think, gosh, there might be something wrong with my hormones. I think we have to recognize, though, um, the um, the limits of the labs that we have, because sometimes, yes, I think if a patient is very stressed, sure, their cortisol level may be high, but our lab assay, the radio immunoassay for cortisol that we have, isn't going to tell me that, right?
Mhm.
And so I think that, yes, could we be having difficulty losing weight due to the stressors in our life? Sure. Yeah. I don't have a problem with somebody saying that or thinking that. But there are a lot of people selling patients a lot of labs that don't have good science behind them, that they work to test what it is that they're testing for. And so, what we don't want to do is ask a patient to pay hundreds of dollars, sometimes thousands of dollars for a
Mhm.
test that really isn't giving us the information that they're seeking. And sometimes this is information that we can find by talking to the person. I think we've come to a place in medicine and healthcare where we're so fast to prescribe or fast to order testing. And some of the answers lie within a patient and that relationship with the patient and that trust that they have in you, and them opening up to you and having the stress relief that comes with that too. And so I think that, of course, there's a lot of hormonal misinformation out there, but the patient is never to blame. I think it's just, we need to do, from a traditional allopathic medical standpoint, we we're in a system that doesn't support us in really building those relationships with the patients, which I think has led to a lot of just the spread of misinformation, because patients are looking for solutions and they're not finding it in the relationships that they have with their doctor. So they're seeking alternative providers for answers to real questions and real symptoms that they're feeling.
You have hit upon so many points there. Let me first start with the labs. So, yes, traditionally, our labs aren't going to detect hormone levels that are off a specific person's baseline. So, it's not in the range of clinical disease where we do need to do a further workup or further evaluation. I always preface my conversation with patients with that as well. Two, I completely agree. To anyone that is searching for answers for their symptoms and coming into offices and asking, what supplements can I take, or what can you prescribe me, what can we test for because I'm not feeling well? I think we do need to shift the conversation to, well, let's start with what you're doing now. Let's talk about your nutrition, your activity levels, your sleep, your hydration, your stress management. Those are five very large categories, each of which take a long time of habit building and consistency, persistency to see changes within. But those five categories need to be addressed first given that the clinical labs and objective evaluation is negative, obviously, I don't think any of us would ever turn away a patient that comes in feeling exhausted, fatigued, or depressed without a proper evaluation. But after all the labs come back and there's a disappointing feeling that there aren't any answers, it's really important to really go back to lifestyle, which is what you have specialized in. So, what are the most common, maybe it's all of them, but what are the most common things that you see from a lifestyle standpoint that our listeners could at least jumpstart with working on?
So, with all of my patients, I do what I call my day in the life history. So, whether a patient has a non-specific or specific complaint, and even regardless of the labs, like, okay, let's say a patient has hypothyroidism. Yeah, we can fix the hypothyroidism, but we still want that patient to have an optimized lifestyle so they can feel their
Absolutely.
best. And so, the one thing that I feel is missed by traditional medicine often, that is just highly impactful and almost always disordered, is sleep. I don't think people get asked about their sleep enough. I think they get told to move more and eat less all the time, but really diving deep, if your patient is fatigued and you haven't asked them about sleep, it's like the lowest hanging fruit, right? And there are people who are shift workers who think it's appropriate to sleep for 4 hours, who are looking at their screen right before bed, who aren't sleeping in dark rooms, who have a bunch of interruptions because they have little kids or pets, or their partner snores or something like that, or they have untreated sleep apnea,
Mhm.
um, or they are very anxious. They have anxiety and it's keeping them up. And all of us go through that at some time, sometimes in our lives, or some phases our menstrual cycle, And so really getting to the root of, okay, yes, you're dealing with fatigue or difficulty with weight loss, but let's see if we can figure out why and reverse that and get you feeling better, and then, build upon that. But I would say
Mhm.
sleep is like the lowest hanging fruit that gets missed way too often, almost always.
I agree. From physicians and from patients, I don't think there is enough emphasis on quantity, quality of sleep when someone thinks about, okay, let me, start improving my life. I'll eat better. I'll move more. I'll be on a regimen. But, binge watching television prior to sleep or scrolling on Instagram, we've all been there. Let's just say we're all not robots. We are human. It is okay, but to build that foundation of sleep quality, I think is so, so important, in sleep hygiene. By the time this episode comes out, there will be an episode about sleep hygiene with a sleep specialist. So, for listeners who really want to do a deep dive on how they can improve their sleep, go back and listen to Dr. Meredith Broderick, who's a sleep specialist that I interviewed. But so, sleep, and then let's talk about a huge problem across America, across the world at least, I think I can say, obesity. Obesity is a chronic condition. Can you explain what that means? I think it's important, or I think it's um, common knowledge that everyone knows high blood pressure is a chronic condition, high cholesterol, diabetes. Those are chronic medical conditions that you go to the doctor for. Obesity now is considered a chronic condition. Tell us why.
So I think obesity it's very sad because it is so stigmatized. And no one would judge someone or have any feelings about somebody saying, "Oh, I have high blood pressure, so I'm going to take this medication." But when it comes to obesity, everybody has their opinion, right? And the AMA has classified obesity as a medical diagnosis for a while now. It is a medical disease. We have a lot of science behind that statement that I just made. There's in all of our weight loss medication studies, we have this scientific approach to why obesity is a chronic disease. And it's just so stigmatized, which really doesn't
Mhm.
help anybody. Um, and I feel that insurance companies and pharmaceutical companies have kind of capitalized on that by making these medications so ludicrously expensive in the United
Yes.
States, that it stigmatizes them even more, because nobody would be talking about Ozempic so much if it cost $50, right?
Okay.
Like but it costs $1,000. And so
Thousand. Yeah.
now there's this whole question of, do patients deserve to
Mhm.
have that amount of money spent on them, when nobody is asking to be sick? Nobody is asking to have obesity and to like want this drug so they can treat it. Nobody wanted to get there. They would much prefer not to have to spend that money. And there's other comorbidities that you're increased risk for. Why are we saying, okay, well, we're not going to cover it for obesity or overweight, but when they have diabetes, once they get diabetes, okay, then yes, we'll cover it then. Like
Yes, such
it's
a good point.
it's nonsensical reasoning, that is only more costly for everybody. And I think, even our people living with diabetes are stigmatized, but at least their disease is thought of as a real disease. But other
Yeah.
diseases are very lifestyle related. Like with hypertension, for example, that's a very easy example because I think it's so not stigmatized. The same lifestyle changes that would improve obesity would perhaps get people off of blood pressure
Yeah,
medications too. And
absolutely.
not in every case, but lifestyle change improves any sort of metabolic health disorder, cardiovascular disease. We don't think twice if a patient has to go get a stent or a cath. Like they needed that. They needed that, right? But when it comes to weight loss medications that could prevent them from ever needing that several $1,000 procedure, hospital stay that could be, six figures, then, or the heart attack that certainly would be a six-figure hospital
Mhm.
stay. Like, why are we not? Why do we think differently about that? And I know part of it is just people and how we think and what we talk about culturally and what the media feeds us. But um, I'm here to say that obesity is something that we need to remove the stigma from. And we need to find solutions on how do we get these medications prices to come down, which is more of a governmental issue that I talk a lot about on my platform. But
Thank you.
we need to talk about, like, not the patient as the problem, but the system as a problem. And how do we
Mhm.
fix the system to serve our patients and to save us all money and heartache and sickness down the road?
Absolutely. You spoke to my primary care heart, where preventative medicine is something that I practice day in and day out. How do you prevent disease before it happens? That's my role. And the fact that we have so many obstacles from a systemic standpoint is can be very frustrating. I completely agree with that. And obesity is stigmatized. It's stigmatized not only within media but within the medical world. I have heard horror stories from patients going to other physicians asking for help, and their first question they ask or kind of drill them on is on their weight, when they didn't ask about lifestyle, they didn't ask about nutrition, they didn't ask about habits. They just focused on the number and the appearance, and it made assumptions, and it really does take a toll on the trust and the bond that a patient and a physician or any medical provider should be building. And then that then trickles down to a decreased trust in other medical providers as they move forward into the medical system. So there's such a big domino effect when it comes to the stigma within chronic obesity. So speaking of chronic obesity and these very expensive medications that you alluded to, let's talk about these weight loss drugs. GLP-1 receptor agonist. That is a bunch of mumbo jumbo to a lot of patients. What is a GLP-1 receptor agonist? Let's first start with examples of the medications, and then, if you don't mind, talking about what it does in the body and how it works.
Yeah, absolutely. Okay, so first of all, GLP-1 receptor agonists are not new. I think a lot of people are like, oh, these new weight loss medications. Well, there was one like in the early 2000s by the name of Byetta.
Hmm.
It's not off the market, but people don't use it anymore because of a lot of side effects and adverse effects. In 2009, liraglutide or Victoza was
Yeah.
approved. We used that for a while, but it was a once daily injectable. And then in late 2017, Ozempic came out. So 2017, that's 7 years ago.
Mhm.
Ozempic came out, and in the endocrinology world, we have been using it widely since then. The side effect profile was better than Victoza. Of course, it's more convenient as a once a week
Mhm. Once a week.
daily versus daily, and weight loss is improved with it at the higher doses. It's actually approved for weight loss as Wegovy. And then in 2021, is that right? 2021, maybe 2022. The years are running together, but Mounjaro was approved. It's
Yeah.
tirzepatide. And that was approved last year for weight loss as Zepbound. So these are not like brand new medications that are hot off the press. People aren't guinea pigs on these. They've been around for a long time. They've gone through a lot of testing.
And
Um,
just to clarify, they were initially approved for the treatment of diabetes, type 2 diabetes. And they still are used for type 2 diabetes and now have also been approved for chronic obesity.
Yeah, and also I think another misconception is that, there have been shortages of these medications, and I hear a lot of patients say, "Well, I can't get my medicine because all these people are using it off label for weight loss." I'm like, "Well, it's not off label actually. It is on label for weight loss. It is FDA approved for the treatment of obesity." So I think that's a misconception that's out there. So what is GLP-1? What does a GLP-1 receptor agonist mean? So GLP-1 is a peptide that's secreted, or like a protein that's secreted from the pancreas, and it has several metabolic effects. One is that when the blood sugar is high, like after a meal, for example, it tells the pancreas, hey, secrete a little bit more insulin to bring that blood sugar down. So that's one way it helps with diabetes. Um, and so, what we'll see in our patients on a continuous glucose monitoring system like a Freestyle Libre or Dexcom is their post meal blood sugars are the most affected by GLP-1 receptor agonists. So, sometimes patients will be like, oh, my blood sugar is higher in the morning and then it's fine during the day. I'm like, yeah, that's kind of how these medications work. It's expected. Um, so, for those of you who might have seen that with your blood sugar, it's not that your body is doing something funny. It's actually working, the medication is working how it should. And they also work on brain receptors. A lot of people with obesity, overweight, um, eating disorders, they have something that we call food noise. Like they're constantly thinking about food.
Mm.
When is my next meal? What is my next meal going to be? Should I eat this? Should I not? I don't want to eat that. Oh my gosh, I overate. All of these thoughts around food. And so these medications actually work on the brain to kind of stop that, like
Mm.
stop that constant food thought, which patients find like freeing. Now my brain can think about other things. Now I can be more
Mhm.
productive, which is a nice kind of side effect of these medications. And they also work on the gut to slow how fast food moves through the gut. So people feel fuller after eating fewer calories. And that is the major way that they cause weight loss. Obesity, we talked a little bit about why it's a chronic disease, but one thing to remember is, we tell people to calorie restrict, eat less, but the problem is the body does not like to lose weight. If it did, we wouldn't have so many people struggling with obesity. Like 30% of adults are struggling
Mhm.
with obesity. There's a huge percentage of even adolescents struggling with obesity.
Yeah.
So the body, when we start to calorie restrict, the body's like, wait, what's happening? Oh my gosh, I'm starving.
Mm.
And even if we would be healthier, 20 pounds lower, the body's like, I'm going to increase the appetite and decrease the metabolism so I can go back to where I was because I don't like this change. And these medications kind of help overcome that increase in appetite that typically occurs with weight loss. Um, and so these medications, they're safe when used in the right patients who have been counseled and evaluated, but they do have potential side effects and adverse effects. Nausea is the most common adverse effect that we see that typically resolves in about 3 to 4 weeks after the body is acclimated to the medication. They should be started at a low dose and then titrated up based on patients' symptoms or side effects. If they're not having side effects, that's a good time to increase if more weight loss is desired or more blood sugar lowering is desired. What we see too often is people are started on a high dose just out the gate, or they're titrated up and told to just like bear it for the sake of weight loss, and they're like throwing up. That's not
Yeah.
appropriate. Um that is not how these medications are meant to be used, nor is it safe. Um and the patient actually has to have like obesity or a metabolic condition. There's a lot of people with a normal weight who are using these medications for weight loss to get to a below normal weight, which makes me concerned about one, body dysmorphia, eating disorders, and playing into that, and also bone mineral density and things
Mhm.
that we know can be periods. People can
Yeah.
lose their period if they lose too much weight, which isn't a good thing either. And so I think the problem with the popularity, which I think is due to two words, social media, um,
Correct.
uh,
Absolutely.
I think the problem with that is now everybody's like, oh my gosh, there's this magical solution to um, weight loss, but it's not. It's a medical treatment for a medical disorder for the appropriate patient by the appropriate clinician. And if not if all of those boxes are not checked, it is no longer safe.
Mm.
And we sh- we shouldn't be okay with people prescribing things that aren't safe.
Yeah, absolutely. So thank you for breaking that down. So, just in summary, these GLP-1 receptor agonists, GLP is a peptide, which is a protein. And these medications will affect multiple areas because remember, hormones work everywhere in our bodies. So, this medication will work one on the pancreas itself to secrete a little more insulin to help lower your blood sugars after meals. It'll work on the brain to help with appetite and that food chatter. I loved how you described that because that is a problem regardless, I think, for a lot of people, but especially in those who are suffering from obesity. um, that is something that I do hear from patients, and I'm constantly thinking about food and what to eat, what not to eat, how much to eat, and guilt after overeating, and it's just this constant cycle, and it's taking up a lot of my bandwidth. So the food chatter is such a good little phrase to utilize that with, and it also works lastly in the gut too to help keep you full longer. So all of these things are benefits to the GLP-1 receptor agonist world of medications like Ozempic. Who should not? You already mentioned those who do not meet criteria, meaning I don't think we broke this down, but BMI above 30 or above, which is the definition of obesity. Now, we know BMI by itself is not a great indicator of health. So, why don't you talk a little bit about the insurance criteria or the medical criteria needed in order to be eligible for these medications?
So that's a very good question and very nuanced. So, um, yes, we have a definition of obesity. Now we know, like, we're both South Asian, right? So the BMI cutoff for obesity in Asians is lower. And so I think that's where really talking to the patient about what is going on and why this might be a good option is probably more important from a medical and health perspective than the numbers alone. And sadly, most insurances do not cover these for obesity. Um, most A lot of them cover them now for diabetes, and even with diabetes, they often have requirements like the patient has to have failed less expensive therapies or has to have a contraindication. The paperwork is quite arduous, and
Yeah.
I'll be honest, some clinics won't even do it, um, which I think is sad and a disservice. On the flip side, I understand because it's time consuming. Like sometimes I have to have calls with other physicians who
Yeah.
are reviewers for insurance companies to get this for my patients with diabetes. And the insurance companies aren't like, oh, let's just schedule a call for this and make it easy. It's like tracking these other clinicians down, multiple voicemails, callbacks. Like, it is a whole thing. It is not sustainable in a traditional insurance based practice at all to try to get these medications covered. And so if you are struggling with coverage, and you think you can get coverage, one, advocating for yourself on your behalf. I had a patient truly who is struggling with obesity. I wrote a really strongly worded letter, called, and then I said, here, write these things. And she was like, yes, I'm going to write these things, and sent a letter on her own behalf. They denied me, but when the patient advocated for herself, she was able to get it.
Interesting.
Yeah, so I think, going that extra mile with the insurance companies wanna make money. That's
Yeah.
the point. Like, they're not a fiduciary to the patient. They're a
Mhm.
fiduciary to themselves. And
Correct.
so it's a very, like, messed up system where actually the doctor's customer is the insurance company because they're
Mhm.
paying, while the patient is the person who they're caring for. And so they've disrupted this relationship where, and then they will tell the patient, oh, your doctor didn't fill out the paperwork correctly to get you this medication covered,
Mhm.
when really they have these asinine forms that are intended for them not to approve the medication. And I'll give a
Yeah.
slightly off topic example. There was this huge article in, I can't remember, Wall Street Journal, New York Times, a big media outlet about Cigna. Cigna
Oh.
flat out denies all vitamin D orders,
Yeah.
like coverage for every single one. Like, they have
Yes.
an automatic denial.
Mhm.
And the point of it is most people aren't going to appeal.
Yeah.
And so anytime you appeal, okay, they cover it. But they're banking on the fact that people aren't going to appeal, which works in their favor. So, um, be your own advocate. And if you are not able to find a doctor who's able to advocate for you in a traditional insurance setting, be compassionate and recognize that they're doing the best that they can within the confines. Yes, some doctors are jerks, but many are not. They're just like, they're trying to do their best in a system that's not
Mhm.
supporting them or their patients. And so, perhaps an alternative direct care route or something like
Mhm.
that might be more successful in getting these medications covered, for you, whether it's for diabetes or obesity. Now, the other avenue for getting these medications covered is if you work for a big company, like your Amazon or Google, or just a big company. Often these companies are self-funded insurance. So you may have a Blue Cross card or Aetna card, but we work a lot with, like, that's our whole Hey Healthy company. We work with self-funded, employers. These companies are incentivized to keep their employees healthy because we know, um, from, like, first of all, it's obvious, but we know through data that healthier employees are more cost effective.
Mhm.
it,
Yeah, no
it's
surprise
it's
there.
not rocket science, right? And
Right.
so when a company is self-insuring or paying directly for your claims, they're incentivized to help you get what you need. And so, um, you can talk to them and go through the appeals process directly with your company if you happen to work in one of those situations. Now, you may not know that your company is self-funded. Like, it may not be
Mhm.
obvious to you because they gave you a Blue Cross card or something like that. That they only do that to because it helps negotiate hospital contracting. Um, but if they so you can, if you work for a big company or even a small company, ask if they're self-funded because they will be probably more open to helping you with
Mhm.
getting coverage for what you really need, especially if they think it can be cost effective over time.
Those are great tips. I think the main message there is be your own advocate. Insurance companies are confusing. They're confusing for doctors. It's important to understand what your plan covers. It's okay to pick up the phone and call, do some research. I feel grateful to work for a large company who we have obesity medicine specialists on board. We have the staff to help with the prior authorizations and all the back end work. But not all practices are equal. And so it's just important to know your avenues, your options as a patient. Go to your doctor and ask these questions. Otherwise, you won't find out. You won't know because the system is convoluted. It's been convoluted for decades. And oftentimes, as a physician, I cannot tell you, the patient, what your plan will cover. I can tell you what is being spit out into data. I can tell you from anecdotal, stories, experience, that, these are the criteria that we need in order to get this covered, or because of prior experiences, I think we're going to have to jump through some hoops. Let me send you to someone that just does this for a living and can help you and me out to get this done in a smoother process. And if your primary care doctor does not have that access, that's where, specialists come on board. Direct primary care, which has a different model of practice, come into play. It's okay to ask questions, but please be patient, because you're right. We are working in a broken system in that traditional healthcare sense, where we are directly or indirectly pressured to see more patients to make more money for the company, not in our pockets. FYI, I'm an employed physician. So I make the same, and I may get, bonuses here and there dependent on productivity, but it's really important to, as a patient, really know or start learning about the healthcare system, which again is confusing. So it's okay if you don't know. I barely know.
Yeah, it is exorbitantly confusing, and also important for all of us to learn about it because it
Mhm.
affects all of us. And also, like, we're all going to be old one day. And,
Mhm.
like, if we don't learn about it, no doctors are going to accept Medicare. or, it's just and our taxes are paying for it. And so
Yes.
it's really important to try to understand this stuff. I'm not saying they're making it easy, but there are also things that you can learn that can be incredibly cost savings, like
Mhm.
tens, 20s, 30 thousands of
Yeah.
dollars cost savings with simple tweaks or questions or um, know how to navigate the system. So,
Yeah. Great call out.
yeah, yeah, get yourself
So
educated.
which patients should not be using the GLP-1 receptor agonist medications? What are medical contraindications for utilizing that?
So, people who have history of pancreatitis or chronic pancreatitis, those are patients that we hesitate to use these in. I will say with Victoza, we had a lot more issues with these medications causing pancreatitis than
Mhm.
we have with Ozempic or Mounjaro. We think that it's usually occurred in patients with gallstones. I personally have been using these medications, Ozempic since it came out, Mounjaro since it came out, and very often. And I haven't seen a case of pancreatitis with either of those medications, whereas with Victoza, I certainly did. So,
Yeah.
um, in our diabetes guidelines, we think it's sort of a relative contraindication. The other issue that comes up all the time that actually is not a contraindication, but can be really scary, is this issue of thyroid cancer.
Yeah.
So the story on that is, of course, these medications weren't first tested in humans; they were tested in animals. They were tested in rats. So were tested in rats who had a propensity for medullary thyroid cancer. And so, what happened? These rats had medullary thyroid cancer. Medullary thyroid cancer is a condition that endocrinologists treat. I have seen it. It is very scary. It
Mhm.
is one of the scariest types of thyroid cancer that one can get. Um, However, it has never been seen associated with GLP-1 receptor agonists in humans, not in studies, not in real life. There's never been a case report of medullary thyroid cancer with these medications. If there was, we would stop using it. But because of what happened in the pre-human testing, um, the FDA has a black box warning on this. If you have a history or family history of medullary thyroid cancer, don't take this medication. So that's something that when we're talking to people about these medications, we need to educate them to
Mhm.
know how to handle what Google will say to them, or what their cousin, sister's mom, or whatever will say to them about these medications, because they are not contraindicated with a history of thyroid cancer. They're safe to use with thyroid nodules. We just need to have patients feel comfortable doing
Yeah,
that.
right. Which,
Um,
yeah, this is a joint decision. You're right.
for sure, for sure. And patients really deserve to be educated on the potential side effects and adverse effects, because they're real. Like, we see the adverse effects.
Mhm.
They're common enough to be common, and these medications are commonly used now. So those are the two big, like, or really one absolute contraindication, I would say. Now, if we have a patient who has issues with bowel obstruction, or issues with gastric emptying, those are patients that I
Mhm.
would certainly take pause in, because they slow how fast the gut moves.
Right.
And so we don't want to be causing more problems with that regard. Um, and then the other big area is people who are normal weight,
Thank
and
you.
I think that um, every medical therapy that we prescribe, we weigh the risks and benefits. And the benefits have to outweigh the risks from a health perspective for us to recommend a certain treatment. And so, if you're a normal weight without any other comorbidities, no diabetes, no um, heart disease, no issues, and this has become a cosmetic reason to use this medication, that is contraindicated. That is not an indication for the use of this medication, because they can cause other bad things to happen to you.
Mhm.
They can make you sick. So the risk has outweighed the potential benefit at that point. And I think we've all been there, right? Like, we've all wanted to look a certain way or feel a
Mhm.
certain way about ourselves. And I get it. Like, I understand the cultural pressures. The aunties, overly
Mhm.
overly interested in your
Absolutely.
appearance, all of those things are real, and we understand. However, it's not worth putting your body at risk. Um, and maybe we need to be having a conversation about body image and body
Mhm.
dysmorphia and those things, which we should address instead of treating with a medication that could potentially cause harm.
That's a great call out. I think the majority of, I wouldn't say majority, let's scratch that. Many patients come in to my clinic asking for these medications. Do we have the ability to prescribe them? Absolutely, right? We can prescribe almost anything as physicians. That being said, it is our duty to weigh the risk versus the benefit of any medication and make sure that it is appropriately indicated and managed for the right medical conditions. So yes, without a elevated BMI, without other comorbidities that you had mentioned, high blood pressure, diabetes, high cholesterol, sleep apnea. I think reflux is one of them, alongside with the actual numbers, the weight. It's really tough to explain to ourselves why we should be giving a patient without a medical condition these medications. So, I guess let's just take a sample patient, a patient with obesity, with risk factors like cardiovascular disease. You start them on, let's pick one, Manjaro. Um, no contraindications from a medical perspective, safe to use. Um, how quickly would you expect the patient to start seeing results in the numbers, in the weight, and maybe their sugars and blood pressure, regardless of what they have associated with it?
Most patients have results like almost immediately with appetite suppression,
Mm.
because the medication feels most potent that first 24 to 48 hours after they take it. So, yeah, most patients have immediate results in that regard. Blood sugar too, within a week or a couple of weeks. We give it about 3 to 4 weeks to see the maximum blood sugar lowering that it's going to get with that particular dose. And weight loss, many patients start experiencing weight loss in that first week, couple of weeks. And so
Yeah.
it can happen very rapidly, which is why we also need to be mindful of lifestyle and exercise, protein intake, strength training, because when you have weight loss, some of it's going to be fat, some of it's
Mhm.
going to be water, and some of it is going to be muscle. Like,
Yeah.
you will have muscle loss with weight loss, and that is to some degree normal. However, if you have rapid weight loss without adequate nutrition and strength training, resistance training, that muscle loss will happen at a much more rapid pace. And that's not what we're aiming for. We don't want somebody to lose so much muscle mass that, gosh, it's hard to go from sitting to standing.
Yeah.
That is not
Absolutely.
okay. So it's really important to counsel patients, hey, you may have rapid results, but please continue or start a resistance training program. um, we will talk about what adequate protein intake is and how to maintain that so that they can continue to optimize their nutrition. In the early times and throughout. And having that optimal resistance training and nutrition may slow weight loss, and that's okay. It is not, even though it would be nice to be safe, but it's not ideal to lose like 20 pounds in 2 weeks. Like, that
Yes.
is not sustainable. It's not safe. It's not what we're trying to do. We're trying to elicit a chronic change in your body that's going to last you time. And so we want to do that more slowly,
Mhm.
with weight loss of zero point 0.5 to 2 pounds a week. That is great. That is
Mhm.
what we're shooting for. When it gets higher than that, we start getting worried.
Yeah, sustainable changes is the goal here. Do you find that patients plateau after a certain period of time when it comes to their weight loss? Obviously, we're not going to lose weight until we're zero. And what do you do when that plateau occurs? Because that could be very frustrating in someone's weight loss journey.
Yeah, so most patients do plateau at a certain point, whether they're using Mounjaro, Ozempic, calorie restriction, anything. And so at that point, we need to revisit dose. We need to
Mhm.
revisit um, meal and nutrition composition,
Mhm.
and calories, because if we started on a calorie range for somebody who is 200 pounds and now you're 160 pounds,
Yeah.
your body might not need as many calories or may
Mhm.
need further restriction to make further movement. So yeah, we definitely see plateauing, and we have ways to um, move beyond it.
And I'm assuming in that specific sample patient that we're talking about, if they stop taking the medication, the injectables, um, given that they've made lifestyle changes, is the expectation that they will gain that weight back?
So many patients will, and it for some patients, they've had chronic issues with obesity their whole life, right? If we're dealing with 30 years of obesity, um, and we start the medication and they start to have improvement, the likelihood that their body is going to go back to where it was prior is pretty high. Patients, if they've made really significant lifestyle changes, changed the way they eat, started exercising, doing things that if they weren't doing those prior to starting, um, they may have more likelihood to keep some of the weight off, all of the weight
Yeah.
off, but they do need to be really mindful of their intake while they're on the medication, and their activity levels, so as to sustain that. it's just very difficult when you
Yeah.
don't have the medication on anymore. Now,
Yeah.
there are some patients who had a really acute episode of weight loss. Pregnancy is one that's common. A woman may gain a lot of weight during her pregnancy, struggle to get it off. GLP-1 receptor agonists are not approved during pregnancy or lactation. So if after that phase of her life is over and she's really struggling to lose the weight, but never previously struggled with weight, that might be an opportunity to use these medications short term. And I have seen that in patients. They need it to get off that extra baby weight and then they don't need it anymore,
Hmm.
because their lifestyle is kind of back to normal. And, that's a really stressful period in life, too. There's a lot going on. You don't have as much time as you had prior to having the baby. And so once they get their routines back, sometimes we can get off of it. Or, other reasons for really rapid weight loss could be okay long term without needing the medication forever. And many people don't want to be on these
Yeah.
medications long term. Um, and so I do think that's a very interesting area and it's actually something that I'm considering a lot and working on, of figuring out, okay, well, how can we set these patients up for success post GLP-1? Because one, that's important for cost.
Okay.
And two, it's just people don't want to be on medications for a long time. Why would they if they could be okay off of it? So figuring out, okay, how do we optimize macronutrients for a patient to
Hmm.
get off of these medications eventually?
Yeah, that's such a good call out. I mean, there seems to be a running theme here. You need to fix the foundation. We need to continue working on appropriate nutrition, appropriate activity level, just to, in general, set a good foundation for true fat loss. And make this more sustainable with or without medications. Even after you stop the GLP-1s, you made a great point. The nutrition plan, the regimen of working out, of exercise, movement of any kind at this point, is important. And I also want to stress the fact that it is difficult to build a habit. Again, with or without medication. I mean, as someone who has gone through very strict nutritional changes for my own health, it is very difficult to change your mindset around food, to change your mindset around activity and exercise. Without medication, humans will plateau. Our bodies are good at adapting. So, plateauing with weight training, plateauing with the weight on the scale, plateauing with anything is part of the trajectory, I think. And it's important to, again, think about this in an objective way without being influenced so heavily on the before afters that you see splashed across your screen, or even stories. I mean, I have patients coming in saying, my friend lost 40 pounds in, a month or something crazy like this. And why is my progress so slow? I'm so frustrated. And it's important to, again, take a step back, 50-foot view. I mean, it's taken a long time to build the weight up. It's taken a long time to build habits. And that is all going to take time to take effect as well. You had mentioned zero point 0.5 to 2 pounds a week is a healthy amount of weight to lose for a sustainable result. Again, it's so important to keep all of this in mind and kind of ignore the noise. Put blindfolds on almost, and have them on when you are going through your journey, whether you're overweight, clinically overweight or not. It's hard to compare different cases when our bodies don't work the same way and our brains don't work the same way. So, just wanted to add to your wonderful point about building that foundation for sustainable health. It's not even, it's past the weight at this point.
I think that's the thing about weight. It's just a number on the scale. And I,
Yes.
I, I guess I shouldn't use just, but I think we use that data point to say, I'm a good person. Or
Yeah.
if, we put so much emphasis on a number that is completely like it's an objective thing. We shouldn't be putting all of our emotions in it. And I get it. I've been there. I think we all
Mhm.
have. We've all felt this way. It's not wrong of you to feel that way. But at the same time, we need to take a step back and recognize that the scale doesn't tell us how stressful your week was. It doesn't
Mhm.
tell us the quality of food that you ate. It doesn't tell us if you did a great job at your presentation yesterday. It doesn't tell us anything except the the objective information that it provides. So if you've been killing it at the gym, you feel great, you're eating really healthfully, um, your bowels feel good, your brain feels
Mhm.
good, all of those things, but the scale shifted in the direction that you didn't want it to, or didn't move down like you wanted it to. Sure, maybe you think about your nutrition and make sure it was as good as you thought it was, but if it was, then that is the important data,
Yeah.
right? And so I think there's a lot of things going on in our bodies, right? There's water, there's muscle,
Mhm.
there's fat, there's lots of things that can affect that number. How much salt you ate, how much salt you didn't eat, how much
Yeah.
did you have a bowel movement? All of these
Yes.
things make a difference in that number that isn't necessarily reflective of whether you did well or bad, And so
Right.
I think
There's a lot weighing, no pun intended, weighing on that number on the scale. And there's a lot of judgment. And again, as you said, it's normal. It's normal for these thoughts to go through our heads, but it is imperative that you recognize the thoughts and you have a reaction to objectify them instead of, recycling through all of these thought processes, which will then affect every other decision that you make for the rest of the day or for the rest of the week. And I still, even though I know all the objective data, being a physician, being someone who regularly works out, I know when, after a leg day, for example, I step on the scale the next day, I'm easily going to gain 2 pounds. My muscles are swollen, they're retaining water, they're trying to heal. That used to put me in this crazy negative head spin of, oh my God, what did I do? What can I do differently? I would calorie restrict. I mean, bad space, long, long time ago. And so it's important to, even though that number may be like uncomfortable and you may not feel your best in that moment, it's important to just, again, 50-foot view. What did you do the day before? Did you poop? Did you get on the scale without pooping? Because that can also retain water and add a little extra weight to you. And it's never a straight trajectory down. It's always a zigzag with an overall trend, hopefully in the right direction. Um, Arthi, you've hit on so many gems in the last almost 1 hour here. We went through what an endocrinologist does. We also went through the importance of hormones, the importance of being your own advocate as a patient. We delved into these GLP-1 receptor agonists and how they work in your body, the pros, the cons, the indications. We even hit on mindset, which is my love language with my coaching. Do you have any last messages to add for listeners today?
um I think just you guys are doing great. Like, give yourself credit for what you do. I think one time my kids made this little craft for me that said, like, I love you because you work hard. I love you because, like, of this that you do for me, and this and this and this and this. And they were all things that I do so mindfully and I never give myself credit for. And I just was like, wow, we need to look at ourselves the way our little kids see us.
Yeah.
And then we'll be doing so much better. So
Yeah.
if you have little ones, look at yourself how those little people see you.
Oh, I love that. It's important to celebrate your small accomplishments because those small accomplishments lead to big changes. I love that. Where can our listeners find you, Dr. Arthi?
Yeah, so I would love for you guys to check out our websites. If you're an individual who wants to see us in clinic, our website for complete medicine is just sacomplete.com. And then if you're a business that wants to work with us to help take care of your employees, our website is real easy. It's heyhealthy.com.
Awesome. And then you want to throw out your Instagram handle as well?
Yeah, my Instagram handle is Dr. Arti Thangudu.
And we will post all of this on the podcast information page so you guys can run to whatever platform you're listening to and click on all the hyperlinks that we'll have for Dr. Arti. Arti, thank you again for taking the time to be here amid a very busy day, I'm very sure.
Oh, thank you so much for having me.
Of course. All right, Beyond listeners, we want to hear from you. So after listening to this episode, send us your questions. You could DM me, you could DM Dr. Arthi, and we can try to answer your questions or address them in a different podcast episode or on Instagram. But I want to know what you guys are thinking. Don't forget to rate and review on your listening platform, and we'll talk later. Bye. Thank you so much for joining and spending your precious time here with me. As someone who prioritizes her energy, I am so grateful that you chose to spend yours here. To help me help you, please take an extra 30 seconds of your time to rate and review the podcast on your listening platform. For more tips and a behind-the-scenes look into my life, follow me on Instagram at Dr. Flora Sinha. That's Dr. Flora Sinha. Finally, connecting with you truly fills my cup. So DM me on Instagram, email me at florasinhamd@gmail.com, repost if you love this episode. I love hearing from you. I am so grateful for you and cannot wait to be back for the next episode. Bye.